The speakers may have received honoraria from Takeda for their participation, and the views expressed reflect the experience and opinion of the speaker. This podcast is available to the general public for informational purposes only. It should not be used for diagnosing or treating a health condition or disease. It is not intended to substitute for consultation with a healthcare provider. Please consult your healthcare provider for further advice.
Welcome to the Universe of Transplant Care, a podcast developed by Takeda Belgium about the patient journey before and after transplantation. You can also watch this episode on YouTube. The universe symbolizes the journey of transformation, and each star represents a role within the universe. The attentive nurse, the specialist, the supportive family member, the psychologist, the pharmacist, the social worker, the dietitian, the physiotherapist, etc. And together they illuminate the patient's path, guiding them through uncertainty towards a good quality of life. This podcast was created to raise awareness and share insights from patients and caregivers. We're recording on location at the iconic Sportkot of KU Leuven, a university not only known for its medical excellence, but also the proud host of the 2024 Belgian Transplantoux Games. A fitting place to talk about transplant care. I'm your host, David Naert, sports journalist and transplant recipient myself, and for this episode, I'm joined by Professor Johan Maertens from UZ Leuven, Professor Karel Wissing from UZ Brussel, and Mr. Ralph Dubois from the patient organization Transplantoux. Welcome everyone. Together, we'll be exploring the medical and emotional journey before and after transplantation, the challenges patients face, and how to improve their quality of life. Now, before we get started, Ralph Dubois, I'll start with you. You're here as a representative from Transplantoux. Can you present yourself and what can you tell us about your organization?
I'm Ralph Dubois. I'm 42 years old, and I'm a liver recipient already 23 years, so it's a long time. And I represent also Transplantoux. It's a Belgian organization who is run by and for transplant recipients to get a healthy lifestyle, to get into the sports and start doing a lot of things after and before transplantation. So yeah, that's what we do.
And on any level, really, working also with plenty of volunteers.
Yes, we have a lot of volunteers. I started myself as just a new member, and then get a volunteer, and I grow in the organization at any level, because after a transplantation, it's not quite easy to start a big climb of the Mont Ventoux, for example. You do some walks, some darts or bowling, and afterwards you can go on. But we like to do it first to the healthy lifestyle, and then the movement and sports.
Okay, well, before continuing, let me first introduce my other two guests on this podcast. On my right-hand side, Professor Johan Maertens. Can you please introduce yourself?
Hello, David. I'm Johan Maertens. I'm a clinical hematologist and transplant physician at the University Hospital Gasthuisberg Leuven.
And on my other side is Professor Karel Wissing. Welcome.
Pleased to meet you too. I'm Karl Martin Wissing, so I'm head of the nephrology department at the Universitair Ziekenhuis Brussel.
Okay, thank you. And we'll be taking a closer look at the challenges these post-transplant patients face in a minute. But first, Professor Maertens, as a hematologist, can you shine a light on hematopoietic stem cell transplantation in Belgium? How many transplants take place here on a yearly basis?
David, although Belgium is a rather small country in the region, we do have a very high density of transplant centers in the country, performing both autologous as well as allogeneic stem cell transplantations. And if you look at the activity report that was issued by the European Blood and Marrow Transplantation Society in 2023, you will see that in Belgium we performed roughly 900 first transplants, slightly more autologous transplantations compared to allogeneic ones, but still around 450 patients received a first allogeneic transplant in 2023. What we've seen in recent years is that there is a gradual decrease in the number of autologous transplantations, and that's because there are new treatment options, especially CAR-T technology is available now for lymphoma and myeloma patients. Whereas if you look at the allogeneic ones, where you use a donor for the transplant, we see a gradual increase in the number of transplants. So things are changing in the field of allogeneic transplantation, but the numbers are still going up year by year.
And Professor Karel Wissing, from a nephrologist point of view, how do these numbers compare to the number of solid organ transplantations in Belgium performed on a yearly basis?
In Belgium, we have a lower number of transplant centers. It's in fact the 7 transplant centers in the main universities. And in 2023, for instance, there have been approximately 1,000 solid organ transplantation. Of these, the kidney transplant are the majority, about 450. And afterwards, it's liver transplantation, also frequent, 310. And then I think there are about 250 lung transplants. Heart transplants are less frequent. I think it was 50 in 2023. 2,000 patients received the possibility to lead again a nearly normal life. We don't. So these are the deceased donors. So you receive an organ from somebody who is deceased, but there are also living donor transplantations. So these are mainly kidneys for the moment, but it's still an emerging activity in Belgium. It was 80 living donor transplants, so much less than, for instance, in the Netherlands, where half of the kidney transplants are done with living donors. And there are also a technique, a split liver, where a living donor gives the left lobe of the liver, which is transplanted in a recipient, but which is more difficult for the donor, the procurement, and there are the numbers are quite stable now over the last years. I think about 25 of these procedures per year in Belgium.
Mr. Dubois, turning to you, can you tell us more about the patients and the patient's journey? What are the main emotional challenges transplant patients are facing?
Yeah, my journey is quite a little bit different than the majority of patients, because I had a short period of illness before my transplantation. I had liver failure, so it was just in 2 weeks. The other ones have a longer period on the waiting list, so that's the difference. For me, it was like the end of my my old life. It was as a young boy who was playing football and things like that, and then it stopped. And I see with a lot of other patients, it's a long journey, and they see the transplantation as a new beginning. So that's a difference. But yeah, in the end, it's for both groups living in extra time, we always say. And yeah, for me, it was the emotional thing that I need to recover my body to see what can I do, what can't I do. So that was quite difficult in the beginning, because I lost the trust in myself. So after that.
And how did you find back the trust?
With a lot of support, starting with Transplantoux, going first time to see something, not to do something. I played football all the time, so it was cycling and walking. I thought, it's not my kind of tea, but I started with cycling and enjoyed it. And the group, I had a lot of support. There were a lot of other patients who has similar stories, and so yeah, we stepped up and that's a little bit, we gained confidence. I had the possibility to go to the Mont Ventoux, to the Mont Blanc. So yeah, it was after transplantation, there was a new world opening and a lot of things that I can do. So yeah.
That's great to hear.
Yeah.
Professors, turning back to you, what are the main physical challenges for these patients? And Professor Maertens, I'll let you start.
Yeah, I think that the physical challenges for our population is different from, I guess it's different from the solid organ transplant population, and it's also phase dependent, depending on whether you look at early after transplant or later after transplant, and sometimes even very late after transplant. Undoubtedly, the most important physical challenge early after transplant is fatigue, and that fatigue can be extreme, even not linked to their blood results. People often think that fatigue is a result of anemia, of low hemoglobin, but even in patients with completely normal blood results, you see that they suffer from the very severe fatigue. That's their main complaint. Another one very early after transplant is the impact of radiochemotherapy on mucosa and mucosal damage. And as a result of that mucosal damage, what we call mucositis early after transplant, they have difficulty to swallow, difficulty to speak, very often difficulty to eat, resulting in anorexia, resulting in weight loss. And that's a second main complaint of these patients. When you move a little bit further away, let's say 3, 4, 5 weeks after the date of the transplantation, then the most important physical challenge is really the result of immunosuppression as well as the graft versus host disease. And that's something that I probably have to explain, and it's different from the solid organ transplant population. Graft versus host disease is an immunological reaction where the donor lymphocytes, the donor white blood cells, or at least part of the white blood cells, react against the recipient. And that reaction may be against different organs. In the beginning, it's usually the gut, the liver, and the skin. And that's what we call the acute graft versus host disease period during the first 2-3 months after transplantation. Can be followed by a more chronic disease, a more like autoimmune inflammatory disease, and in that more chronic graft versus host spectrum, basically every organ can be targeted, resulting in severe dryness of the eyes, of the mouth, can be mobility problems because of joints and muscles. Not everyone has it, but at least 20 to 25% of the transplanted population will have chronic graft versus host disease in some way or the other. And then obviously these patients remain immunosuppressed or immunodepressed for quite a long period of time. It can be 3 months, 6 months, up to 12 months and even longer. And that period is then linked with the development of infections, not your usual bacterial infections, but more what we call opportunistic infections, the viral ones, the fungal ones, parasitic infections. So I think that these are the main physical challenges of our population.
And Professor Wissing, what about the patients going through solid organ transplantation?
Yeah, the difference with the hematopoietic stem cells is in first place that there's a surgical intervention, which is still quite benign for kidney transplant, but which is very taxing for the patient for a heart or lung or a liver transplant. These patients spend some days at least in intensive care and afterwards have to recover from their surgery. And then in the early post-transplant period, the first 3-4 months after transplantation, there's the highest risk of rejection of the graft. So it's the period where patients receive the highest amount of immunosuppression. Rejection can be a problem in psychological terms because you fear that you will lose your graft and then you need intensive immunosuppressive therapy. It's also the period where there is the highest risk of infectious complications. Kidney transplantation, once they pass through these first 3 to 6 months, they have quite a good situation, which you can consider better in terms of physical condition than when they're on dialysis. But in the long term, there are still physical challenges. On the one hand, you have the long-term complications of immunosuppression, like steroid-induced osteoporosis. About 20% of the patients develop post-transplant diabetes, so problems with glucose metabolism. And then there is still, in the long term, a risk of some types of infections, which can be chronic, like infections with BK polyomavirus and also cytomegalovirus infections. But in general, and you're an excellent example of this, most transplant recipients, solid organ recipients, recover an excellent condition in the long term. And I think this is one of the things it's important what you said, that from a medical point of view, I'm in transplantation since about a little bit more than 30 years. When I started, it was the organ. Everything was focused on maintaining the function of the organ. I think what you indicated, what is very important, that we also have to consider the patient. And as you said, you didn't feel well and you needed support. I think one of the things we have to do now is effectively put the patient at the center.
And in that sense, it's great to have testimonials like yours, Mr. Dubois. Yeah. If you look at the post-transplantation period, in your experience, what are the main factors for maintaining and improving your quality of life?
Yeah, and it was, for me, it's quite a big change before and after. So I had no medical history, and I need to go to the hospital. The first weeks it was like the professor said, after the transplantation, the scars that need to heal and things with that, that was the problem. And then it was changing to what kind of medication in the morning, in the evening, a lot of cortisons, and after transplantations my muscles were gone. It was like it was pudding in my legs, and I need to recover. And then the combination with the medication, because I was young, and then it was too high, too low. I had a lot of headache, a lot of other problems with stomach. I didn't get medication in and things like that. But when that period passed by, it was like 3-4 months. It gets the water gets easier, and the journey continues. But and 1 year after it, I have a rejection from eating cheese. It was like that was the cause of it. I had an infection, and everything starts over again. So you need to reconsider everything, get in touch with the doctors a lot of. So it was quite challenging for me after the transplantation. But now everything is okay, and the medication is.
A recipient for such a long time. Looking back now, what did you actually consider doing to I can try and improve my quality of life here? Yeah,
and also there's a lot of a big difference between 20 years ago and now. The care of the professionals, they are much more interested in how are you as person, and not like Professor said, not only the thing about how is your organ doing. That's very nice for me as a patient. Yeah.
Okay, and it's maybe a kind of medical sounding question for you, but how is quality of life measured in post-transplant patients, and what do you measure exactly?
What measured a normal life is doing the things a normal person could do. Go to a festival, go to family.
Work?
Work, work, of course. I work full time, so in the beginning it was quite difficult to get there, to work full time. But now with some adjustments, its work is quite fine. And I lead a normal life in my family with my friends, and that I think is the most important thing to do in my extra life. So.
And people often say, if you've had a transplant, it's important to maintain some sort of physical activity. You obviously would agree.
Yeah. I see it by myself. If I do less in winter, before, for example, I do a little bit less cardio training, and I get my weight gain, and I see it with my results. If I go with my doctor, he said you need to be on sports again because my medication level increases then. So for me, it's very important to do a lot of physical activity, a normal level of physical activity to maintain healthy and to go further.
Question for the professors now. Can you elaborate on the benefits of effective post-transplant care, such as reduced hospitalization rates or long-term patient outcomes? Professor Maertens.
Yeah, it's amazing just listening at what my colleagues from solid organ transplantation mentioned, and also what Raf mentioned in his testimony. We face the same challenges in the post-transplant course of stem cell transplants and solid organ transplant patients. Raf mentioned corticosteroids and all the side effects linked to that, osteoporosis, the development of diabetes, interaction with other drugs, the whole use of calcineurin inhibitors and in drug-drug interactions, incompatibilities. So I think that's all the same. And it is important now to look at those post-transplant follow-up moments. For stem cell transplantation, we see patients during the first 3 months on a weekly basis, at least weekly. It might even be twice weekly, depending on their blood results. And then we reduce it to every 2 weeks, and finally by 6 months we go every month. But we always keep on following these patients, similar to the solid organ transplant population probably. So once a stem cell transplant patient, always a stem cell transplant patient, even during that yearly follow-up. And what is important, well, you look at early potential adverse events or problems that can arise after transplantation. Obviously, you look for infections, early diagnosis, early treatment of infections, that's important. Side effects of the medication. We definitely look for signs of graft versus host disease and try to intervene. But on the long term, you look for these long-term side effects. Development of secondary cancers, for instance, skin cancer is a problem in our population. Ophthalmologic problems, all kinds of organ dysfunctions may happen after transplantation, not necessarily during the first weeks or months, but it may happen years later. The classical example of that is lung dysfunction that may be seen 3, 4, 5 years down the road as a result of the chemo or the radiotherapy. So I think that post-transplant follow-up is really very important to try to reduce the morbidities that are linked with the whole procedure. And that also includes, as Ralph mentioned, physiotherapy, dietary advice, vaccination policy, something very important in our population, trying to prevent infections on the long term. So you have to look, it's a kind of holistic approach. You look at all the different elements of a transplant patient. So it's not like sending a patient to a cardiologist or a nephrologist or something or some other specialty. You have to look at everything and combine everything during that follow-up visit. And well, it's challenging, but at the same time very interesting to do that.
And what about you, Professor Wissing?
Yes, your question was the added value of specialist transplant care. So at least in nephrology, the situation is quite a little bit different from hematopoietic stem cell transplantation because during this early post-transplant period with a lot of complications, all transplant patients are followed in a transplant center. We even see them 2 times per week during the first 2 months. But after the 3rd month, in general, patients return into the care of their referring nephrologist. So a lot of transplant patients are followed in peripheral dialysis units by their nephrologist. to my best knowledge, I don't think there's any evidence researching whether being cared for in the long term in a university transplant center gives better outcomes than in a peripheral center. I think what is important is that there's a good communication and collaboration between the nephrologist taking care of the transplant patients and the transplant center. So, because we talked quite extensively about this, the problem of adjusting the immunosuppressive medication, early diagnosis of infections like CMV and BK polyomavirus, adjustment of immunosuppression, possible drug interactions. It's clear the earlier you detect the problem and the earlier you intervene, the less is your chance that you have serious complications. So I personally am convinced that a specialist post-transplant follow-up has beneficial effects, but I don't know whether there is a lot of scientific data to prove that. I think another aspect which is very important, and there's quite some data on this, is patient compliance and also patient education have been shown to be major determinants in a good outcome. In my opinion, there's a large role for specialist transplant nurses, transplant coordinators who take care of effectively educating the patients how to prepare the medications, how to take them regularly, which are the warning signs where they have to immediately contact the transplant center. And I think there's a big role for allied health professionals which are specialized in transplantation, which can really improve the quality of care.
You already touched upon this. One of the most important post-transplant threats are infections, particularly for immunocompromised patients. So how high is actually the risk for infections, and which infections are most common in your experience?
Putting a precise number is difficult because the risk of infection depends on the moment after transplantation, much higher early after transplantation. Then it's after kidney transplantation, urinary infection because they have a bladder catheter, eventually wound infections, eventually pneumonia after the anesthesia. And then rate of infection is higher when you give intensive immunosuppression and in high-risk patients such as older recipients. I would, a rule of thumb estimate, I don't know, have precise data, but I think certainly about 50-60% of patients develop some form of more or less serious infection during the first year after transplantation. And as for other categories of patients, cancer patients or others, you have to detect them early and to treat them efficiently to avoid serious complications like sepsis or organ damage like a transplant pyelonephritis.
And what are the most common infections in your field of expertise?
In my field of expertise, it's bacterial infections. It's clearly urinary tract infections in the kidney transplant recipients because of immunosuppression, but also because the transplant is in one of the fossas and the ureter is implanted without a real protection against reflux. So there is quite frequent urinary infections. And in terms of viral infections, about 20% of patients have some form of detectable replication of BK polyomavirus, BK nephropathy, when the virus gets into the kidney and damages the kidney. This is about 2 to 5% of the patients. And we already have talked, or we will talk about cytomegalovirus, and there, in spite of prophylaxis after transplantation, about 20 to 30% of the patients develop some form of CMV infection after transplantation. So this is also quite frequent.
Okay, same question for you, Professor Maertens. So how high is the risk for infections with your patients, and what are the most common infections?
The most common is quite similar to what was just mentioned. Just can say that the incidence rate in our population is significantly higher. It's very rare to see a patient in a transplant journey without a single infection. Not always severe infections, but I would say that almost 100% of my population will develop infections. Similar to the solid organ transplant population, there are specific stages after transplant that are linked to certain infections. So for instance, the first phase after transplantation is characterized by very low white blood cell counts, basically zero, which is called the period of neutropenia. And during that phase, despite the use of different prophylactic agents, we see the development of bacterial infections mainly. That can be catheter-related bloodstream infections, that can be pneumonia. Sometimes we have colitis caused by Clostridium. Not often, but we do see patients with yeast infections, with candidemia, but all of that is linked to the absence of normally functioning neutrophils. And then 2 to 3 weeks after the start of transplantation, the neutrophils recover. So then you see a decrease in the number of bacterial infections, but then as a result of the ongoing immunosuppression, we see the viral reactivations and the viral infections. And they are not different from what was just mentioned by other colleagues. We see the herpes simplex and the herpes zoster virus reactivations. Usually these are not lethal, although we have seen patients dying from these infections. But cytomegalovirus clearly is and has been a problem for a long period of time. The same with Epstein-Barr virus that may result in post-transplant lymphoproliferative diseases, including specific lymphomas. Polyomavirus was not known to us for a very long time, but now that we use cyclophosphamide as a way to deplete T cells in the graft in vivo, we do see an increase in polyoma-induced cystitis, which is different from what you see in solid organ transplantation, where it's usually affecting the kidney. But in our population, it's mainly the bladder. And then more later in the transplant course, when they develop graft versus host disease, receive more immunosuppressive treatment, receive the corticosteroids, there's about an 8 to 10% rate of invasive fungal infections. Pneumocystis being one of them, but we do see quite a number of Aspergillus infections, some rare mold infections, mucormycosis, pseudosporiosis. So the big three are really bacterial in the beginning, followed by viral, and then more towards the end, the fungal infections.
It's clear that these infections are the most challenging complications for both patients and healthcare providers after a transplant. So can you elaborate on how managing these infections effectively contributes to better transplant outcomes?
Well, at least for stem cell transplant patients and the stem cell transplant population, the answer to your question is quite easy. If you manage them adequately and early enough, then you will reduce mortality. And if you don't manage them at all or too late, then you will have a high mortality rate. Not all these infections are lethal, but the vast majority of these infections, even so-called common or benign infections that we normally see in other populations, may be rapidly progressive, may be overwhelming, and may be rapidly lethal in that severely immunocompromised population. And even if they are not lethal, they are associated with significant morbidity. So also the non-lethal infections, for instance, herpes simplex virus, as we mentioned, can result in severe morbidity to these patients.
I have the same question for you, Professor Wissing.
Yeah, it will be about the same answer, because it's clear that serious infections which cause hospitalization, possible vital organ damage, damage to the graft, have a major impact on the quality of life of the patient, and also associated with a risk of death. So this is clearly a major problem. In transplant patients, there's a clear association. There are three factors: the intensity of immunosuppression. We heard that clearly hematopoietic stem cell transplantations have a much more intense immunosuppression than our patients, and this reflects in this very high incidence, and also infections we rarely see, like a diffuse fungal infection, lung aspergillosis. It's in kidney transplant patients, it's extremely rare. So intensity of immunosuppression, the risk profile of the patient, and this is something we have older and more fragile patients now increasingly with frequent comorbidities, and it's clear they have a much higher risk of infection, and then it's the risk of recurring infections in these high-risk patients under immunosuppression. So these are clearly the challenges, and there we cannot change the risk profile of the patients. So the only way out is rapid diagnosis, efficient treatment, and in the long term, eventually, if it's possible, adjustment of the immunosuppression.
And from what moment do these infections become problematic, and what is the impact on patients and their quality of life?
Well, at least for stem cell transplant patients, as just mentioned, their degree of immunosuppression is probably the highest among the transplant populations. All these infections are problematic from the beginning. If you don't detect them early and act upon them effectively as soon as possible, in combination with trying to taper the immunosuppression, these ordinary infections at the beginning will evolve very rapidly, will become overwhelming infections, and if not treated adequately, many of these patients will end up in the intensive care unit for mechanical ventilation, etc. They are always problematic from the very beginning. Mm-hmm. And they do come with a lot of other challenges. The fear of complications for patients having such an infection, fear of complications, even the fear of dying, because that's something that you have to tell patients. If they have a disseminated fungal infection, you just have to mention that the risk for dying is really high in that population. The fear of being readmitted or having to stay in hospital even longer than the usual 4 to 5 weeks for our transplant patients. The fear of taking even more medication with problems of compliance, of toxicities, of allergies, etc. And sometimes for these patients, you have to put them back to isolation, or you have to put them in isolation because they have a pathogen that is contagious or highly resistant. And so you interfere with their social capabilities by putting them in an isolation room. So the impact of all these infections, even so-called ordinary infections, can be extremely high.
And I guess, Professor Wissing, your answer would be quite similar.
Yes, and I very much like the remark you made. There is no infection that is not problematic, because a BK nephropathy has started as a small replication, and a diffuse fungal infection started as a small one. So the real challenge is for the physicians is to prevent that patients are in a situation where they have life-threatening disease, which entails prolonged hospitalization in a certain sense. And there we go back to the need for close follow-up and the quality of the follow-up to have systems in place where there's early diagnosis, efficient treatment, and you prevent that patients arrive in these situations in the first place.
Well, being a transplant patient myself, I can share this. I'm still worried about catching whatever, and it was exceptionally so in the first month following the transplant. Prof. Dubois, I guess your tale is the same as mine.
It's the same. The first weeks, months, even now, it's you're always in the back of your mind, busy with it from what does it take, especially in the COVID period. They don't have a lot of data on what's going on, of what can they do. For me, in the beginning, it was like how the medication level go up and down, and how do you feel with it, and it was. I was very careful in everything I do, where I went to, with who comes at home. But through the years, it changed, and I know what I can eat, what problems I can expect when I do something, especially before I go to a festival. I know the week afterwards I'm sneezing and things like that. So yeah, I know, but it's not a high risk, I think, and I'm willing to take. But yeah, it's always in the back of your mind, and yeah, the quality of life, you take the best of it, and the medication that you need to take from the doctors, you need to take at the right moment. If they said you erase some medication or take less of medication, you follow it up and you do it. You don't do it something on my own. If there's a problem, my wife calls to the doctor or to the and ask from what's the problem, what do I do? Do I need to come in, or yeah, it's always there. But it's okay with the good professionals in Belgium. So, yeah, easy to phone, to mail, to reach. Yeah.
And here we are, living a good life.
Yes.
Well, thank you all for joining today's conversation and participating in the first episode. Well, it's clear that the transplant journey is a complex one, and in this episode we've taken a closer look at what patients might face before, during and after transplant, and we also looked at the critical role of infection management. In our next episodes of the Universe of Transplant Care, we'll be taking a closer look at how you, as a physician, can effectively manage CMV infections in both solid organ transplantation and hematopoietic stem cell transplantation patients. All episodes are available on our YouTube channel, and if you are a healthcare professional and want to learn more about this topic, please stay tuned for the next episodes. Thank you for having joined us for the first episode of the Universe of Transplant Care.
All references and source materials can be found in show notes.